is a journey from a worm in the anterior chamber to a worm in a vial. The worm was in her anterior chamber when a 32-year-old female presented to us with complaints of a web-like structure moving in front of her left eye for a month. Her visual acuity in both the eyes was 6 by 6. The anterior and posterior segment was within normal limits except a highly motile thread-like worm was found in the anterior chamber. Anterior chamber wash was planned to retrieve the worm alive, and diethyl carbamazine 150 mg BD for 3 weeks was given for an antifilarial therapy. To retrieve the worm alive, it is important to restrict the movements of the worm, for which we tried an innovative approach, that is anterior chamber compartmentalization, where we replace about 2/3 of the aqueous with viscoelastic to create a visco compartment so that the worm is restricted to the aqueous compartment only. Then the worm was aspirated in toto using a 23 gauge cannula. This surgical video demonstrates the technique of anterior chamber compartmentalization. A 30 gauge needle was entered into the anterior chamber from the limbus and about 2/3 of the aqueous was aspirated. Then viscoelastic was injected by the same syringe to create a visco compartment. The movement of the visco wave can be seen. The motility of the worm were restricted. The needle was then taken out and a paracentesis was made. The worm was then aspirated alive and in toto using a 23 gauge cannula. The worm can be seen inside the syringe. Now it was transferred to a vial containing a balanced salt solution. We can see the worm dancing and coiling on itself in the vial. Then it was sent for a microbiological examination in a formalin solution. On the post-operative day 1, patient became symptom-free and the eye was quiet. Topical antibiotics, steroids and cycloplegics were given. The worm was identified as an adult female loa loa. The loa loa is an endemic in rainforest and swamp areas of Nigeria, West Africa, and that is why it is called the African eye worm. Its stage 3 larvae, L3, are transmitted to humans by the deer fly vectors Chrysops silica while taking a blood meal. Infective larvae, L3, matures to adult L5 in the subcutaneous tissue of the human host, after which the adult worms, assuming the presence of a male and female worm, mate and produce microfilaria, and the cycle of infection continues when a Chrysops fly takes a blood meal. Other than loa loa, Brugia malai, Wucheria bancroft and Angiostrongylus are the common parasite found in the human eye. The clinical presentation and management are almost the same. The worm can cause ocular discomfort and inflammatory changes. It can also cause caliber swelling due to the subcutaneous presence of adult worms. Regarding surgical management, the major problem is the worm is highly motile. So, there is a risk of worm loss during surgery. Parasite washout with the gush of aqueous on making paracentesis has been reported. Literature suggested paralyzing the worm to restrict its motility using chemoparalysis. But this can cause the death of the worm. The dead worm can in return release toxic substances which can cause a reaction. So, our purpose was to remove the worm alive. We proposed mechanoparalysis against chemoparalysis, where OVD's compartmentalization causes mechanical paralysis of the worm and impedes its motility, which is safe and also facilitates retrieval of the worm alive. Use of viscoelastic has been reported in surgical retrieval of worms, but no one has talked about mechanoparalysis of worms by the anterior chamber compartmentalization. We used a needle to aspirate aqueous and inject OVDs instead of paracentesis to avoid worm loss while making paracentesis. We also made paracentesis in an area opposite of the aqueous compartment, which facilitates the aspiration of the worm in a controlled way. In conclusion, our technique of mechanoparalysis is easy and safe and also helps in toto retrieval of live worms, in contrast to chemoparalysis where chances of damage or death of the worms are very high. Thank you.